Kia ora everyone and welcome to this Goodfellow webinar on hypertension. My name is Dr. Grace Lee. I'm a general practitioner and tonight I have with me Dr. Hari Talreja, who is a consultant nephrologist and hypertension specialist. All right, let's get to it. Over to you, Hari.
Thank you so much, Grace, and thanks for asking me to talk about hypertension again. This slide sums up my background, and just to say that I've been formally trained in hypertension and had a fellowship in that, and followed by certification by the American Society of Hypertension. I work in both private and public settings. So public, I'm at County Spinnaker Health. Private, I go to Ponsonby and Ormiston, and next month I'm going to be starting at Medical Specialist Center in Epsom. And below is my email address in case you want to contact me for any questions or any other reason. I have nothing to disclose. So for tonight's talk, basically, there were three important things which I thought would be useful. One is obviously to talk about the medications which are going off the market, which is the main important thing right now for us to know. But the other important things are also the targets for hypertension. What's the goal blood pressure that we need to target? And also discuss a little bit about hypertension in the elderly population, because they could be a bit challenging, and there's a bit of confusion around how aggressive we should be. So what I've tried to do, I've tried to put all these three objectives in a case, and it'll make sense as we go along discussing that case. So let's begin with a case. So let's say a 73-year-old gentleman walks into your clinic for a review. Just FYI, this is a different person, not the one you're thinking about. This is Mickey, not Donald. So he's also a very high-fly person and has a very stressful and busy job. He's a current smoker. He consumes alcohol only on social occasions. In terms of his past medical history, it's been significant for dyslipidemia for the past 3 years. Notably, he's not a diabetic, and he does not have a history of hypertension or any cardiovascular issues. There's no history of CKD. In terms of family history, his father is a hypertensive. So you see him, and he's currently on these medications, atorvastatin, and he takes ibuprofen on and off for some arthritic pain or backache. In terms of an exam, his pulse is 70 beats per minute and regular. You found that the blood pressure is elevated, so you've checked this on 2 occasions to be doubly sure. He's got a few extra kilos on him. His BMI is elevated at 29. You do a thorough system exam, and it's essentially unremarkable. In terms of labs which are available to you at this point in time, there's a serum creatinine which was 80, so the GFR is normal for his age. His total cholesterol was 4.3 with an HDL of 1.3. So essentially a 73-year-old with dyslipidemia and elevated blood pressures in your clinic, and now you're thinking about how aggressive you're going to be in terms of managing this patient. So to help you with that, you do a cardiovascular risk assessment. For that, you look into the PREDICT calculator, risk calculators. I have put in the link at the bottom of the slide. This is one of the links where you can use this tool. So PREDICT essentially is a local tool, and it gives you a 5-year risk of any cardiovascular outcome. And it's nice to kind of see all those smileys in front of you, and it helps to kind of explain the patients what the risk is, and it becomes very easy to kind of talk to the patients with this. It also gives you a number, which is in this case 15.7%. This is the probability of an event in the next 5 years. So this number is fairly high, which means you're going to be aggressive in terms of managing this patient and controlling his blood pressure. So you show this to Mr. Trump. You also show him that this is his baseline risk. We said 15.7%, but the calculator would also tell you what will be that risk if you start him on any blood pressure medications. And that risk reduces to 11%, so 4.7% benefit in terms of risk reduction. And so you've shown this to the patient is happy, and you're planning in terms of starting the treatment. Now, just for people who are not very familiar with the PREDICT risk calculator, It basically gives you 5-year predicted cardiovascular risk. So if the risk is low, then in terms of management, you can manage the patient with just lifestyle modifications, so exercise, sodium restriction, eating healthy, and losing those extra kilos. But if the risk is moderate, which means between 5 to 15%, then it has to be a shared decision, which essentially means you're going to explain to the patient what are the risk and benefit of starting treatment, basically starting pills. And based on that, you're going to make a final call. If the risk is high, which is more than 15%, as in our case, then you're definitely going to treat this patient with medications because the benefit is more than the risk. And in case somebody's blood pressure is already elevated at more than 160/100, then you're going to start this patient on medications. So this model basically helps you plan the management. So it's a useful tool. I'm pretty sure most of you all are quite familiar with this. So your impression of this case is?
Hari, do you mind if I just ask a couple of quick questions here?
Sure.
Someone's just wondering where the source of that particular link comes from, and also just a question around how does the predictor compare with the other cardiovascular risk tools that are available?
Right. So a few things of differentiation. So firstly, to answer the first question, that's one of the places where you have the link will give you all different kinds of calculators. So you can actually do a nice comparison between Framingham risk calculator as well as New Zealand predict calculator. The differences being the predict calculator gives you a 5-year risk, and Framingham gives you a 10-year risk. Now, previously I was used to using the 10-year risk model, but this is based on New Zealand population. That gives you that extra flexibility of inputting, let's say, ethnicity. So if somebody's Indian, somebody's Maori, then you can enter those variables and that'll give you more specific. So this is relevant to our patient population, hence being encouraged. The reason why 5-year risk is more important because it's more short term, and also most of the studies that they've used to calculate have a shorter outcome period. So I think this is more relevant for our patient population, and therefore I think this is a useful kind of tool to use.
Thank you.
So the impression in this case is that the patient has hypertension, which is stage 2, if you want to use the old school kind of staging of hypertension. And then given that the risk is high, more than 15%, you plan to start the patient almost jump on antihypertensive medications. But as you're thinking about this, there are a few questions which are coming to your mind. What are they? So the first and foremost question is, if you start this patient on treatment, what goal blood pressure are you looking for? What's your aim? So this patient is non-diabetic. So if you go by the previous guidelines, you're probably happy with less than 140/90, or maybe because the risk is high, you should be targeting a lower blood pressure at less than 130/80. Or more recently, there's been more talk of less than 120/80. So which goal of blood pressure you should be aiming for? That's one of the questions you have in your head. The next thing is which antihypertensive you should be starting this patient on, which is the most appropriate antihypertensive for somebody who's 73, non-diabetic, and you want to, this is the first pill he's going to take for blood pressure control. The third thing is over a period of time, this patient is going to have issues with his age. He's already 73, and he might have other comorbidities down the road. So what all things would you keep in mind when you start treating in this age group? So to answer the first question, which is what blood pressure target would you be looking for? When you're not sure, you're obviously going to refer to some guidelines. The trouble here is there are heaps of hypertension guidelines. To the extent that this causes confusion in my own department with my colleagues and my registrars who don't know which one to follow exactly. The reason is there are heaps of them. So I've just put in a slide, and just to give you a sense of the different societies and different guidelines that come out of these societies, and this is from 2011 to 2015. I didn't even bother going past that because I think I made my point here that there are so many different societies with different interpretations and different thresholds, which causes confusion. to the extent that there was a special focus issue on hypertension guidelines, and this is an interesting article titled Hypertension Guidelines in Need of Guidance. I like the way the author described it. The multitude of guidelines from respected professional bodies and individuals have caused, in my opinion, needless confusion bordering on chaos. So, I mean, I made my point here that there are too many different bodies giving you different opinions, so that's kind of causing confusion. There's no one single answer. So where exactly is this confusion? Confusion is what's the lowest blood pressure you want to target, what's your threshold, and how low can you go in individual patients. So just to give you a sense, again, these are different guidelines over a period of time. They divide generally people into diabetics, those with chronic kidney disease, and the other population, and they give you different thresholds. So this could be quite confusing in terms of which one should you follow. As we were looking at the previous guidelines where it says, okay, maybe if in general population less than 140, 190 is okay, then came the landmark trial called SPRINT. And I think quite a few of us are familiar because we've discussed this. You probably would have discussed this on many occasions. Now, I won't go into the details of this trial, but just to say this was a randomized controlled trial of a big number of patients which looked at intensive blood pressure control versus the standard blood pressure control. And to summarize the findings, when they targeted a blood pressure of closer to 120 systolic, they had to use more than 2 medications to achieve that. It reduced the cardiovascular events by about 25 to 30% in those receiving intensive treatment as compared to the standard blood pressure target of 140 over 90. So what this study did is it changed practice. So that's the reason this study is known as a landmark trial, because it ended up changing practice. One of the ways to look at this, how it changed practice, is this is the Canadian Hypertension Education Program guidelines. I'm a little bit biased. I did my fellowship and training in Canada, so I do have that little bit of soft corner for the Canadian guidelines, and also because my own teacher is part of this hypertension guidelines, but I find them really useful and they're quite simple. But just to give you a sense, this is on the left side is before the SPRINT trial. And after the SPRINT trial, they added an extra row here for select high-risk patients, which was exactly the population in SPRINT.
I think Hari has just had some connection issues. We'll just wait till he comes back on board, everyone.
So we were at the point where I was talking about this CHEP guidelines, and they've released these 2020 highlights, and they were essentially talking about the high-risk patients where the blood pressure target is less than 120 systolic. Now, just bear in mind that this blood pressure is on automated machines, so the ones which were used in the SPRINT trial, not the manual readings which we have generally in our offices. So this is the AOBP, which is automated oscillometric blood pressure, less than 120. The difference is about 5 millimeters. This automated blood pressure machines tend to give you a lower reading by roughly about 5 millimeters. So what are these high-risk patients? So anybody with a cardiovascular disease, be it clinical, be it subclinical, or chronic kidney disease, or an estimated 10-year risk of more than 15%, or age more than 75, these would be the high-risk patients of having cardiovascular events, and you're going to target lower blood pressure in these patients. So where does our patient fit into this? Our patient fits in here. Mind you, this is 10 years. Our patient already has a 5-year risk, which is more than 15%. So for our patient, we're going to follow this guideline. So we're going to start treatment if the systolic blood pressure is more than 130. This is automated. More than 135, it's manual. And then you're going to be targeting a goal of less than 120 systolic. Or if you're going to use a manual, it's less than 125. So the first question is clear in your mind now, based on the recent guidelines and based on the SPRINT trial, that you're going to look at this. The goal blood pressure will be number 3, less than 120 systolic, automated, or less than 125 by office. Now, next is what medications are you going to start him on? What's the most appropriate antihypertensive for this patient? So the first line which has been recommended include ACE inhibitor or angiotensin receptor blocker. For all practical purposes, they are interchangeable. So you can use either from either an ACE inhibitor or an ARB. The second class, which has been shown in trial to be quite effective, is a diuretic. And the third one is a calcium channel blocker. So you could use either of these 3 as a first-line antihypertensive. So now you've got this plan in your head. So you come up with the final plan for this patient at the end of your first visit, and you explain to the patient that it's important for him to change his lifestyle. This is really important. That means dietary sodium restriction, increase physical activity, try and lose some weight. He must stop smoking. That's going to reduce his cardiovascular risk. He must avoid NSAIDs because NSAIDs can increase the blood pressure, a very common cause of that. You decide that this patient has a blood pressure of more than 160, so you're probably not going to be okay with just a single pill. And to improve adherence, make sure that he's taking his pills regularly. What you're doing is you're using a combination pill of cilazapril-plus hydrochlorothiazide, just one pill a day in the morning, and that should help blood pressure. It's routine practice. If you're starting any of these classes, generally you would like to repeat the blood test, including renal function and electrolytes in a couple of weeks, just to make sure there is no hyponatremia or hypokalemia and the creatinine is stable. And then you ask the patient to come back after these results are available. So he comes back to you and you inquired about the medication. He's taking the pill quite religiously, so that's good because many times these patients at the end of first year, you'll see about 1/3 of the people will stop taking the pills on a regular basis. He's not had any adverse effects to the pills and he's not reported any postural symptoms. So you'll find that the pill is working, but not enough because his blood pressure now is 150/84, so still quite above our threshold that we're targeting for. He's repeated his investigations. There's no problem with the electrolytes. His creatinine has jumped up slightly, but still within the normal range. It went up from 80 to 94. So what next should we do? So you've already put the patient on cilazapril-plus hydrochlorothiazide. So in your head, you're not thinking about what should you be doing. So one option is continue the same pill at a higher dose. Now in New Zealand, we generally say cilazapril, we max out at 5 milligrams daily, but elsewhere you can still, in some of the other countries, and you can check it out on UpToDate as well, you can go up to 10 milligrams of cilazapril. And hydrochlorothiazide is at a really low dose, so you can just double this. So instead of one pill, he takes 2 of the same. The other option is you continue with this pill and add something else on top from a different category. The third one is you forget about this combination pill and then you put him on an ACE inhibitor and calcium channel blocker. Now, this combination was shown to be superior to this combination of ACE and diuretic in accomplished trial. So there is more, thrust towards using this combination based on just that study. So as you were thinking about the first and second option, which was increasing the cilazapril-plus hydrochlorothiazide, you just realized there's a notification from Pharmac, and it says that from March 1st, which went by, this pill is no longer funded for new patients, right? And those who are already on it, they might need to change into something else in probably a month from now. So while you were planning for increasing this pill or adding something onto it, now you are in a dilemma because you have to change into something else. So you were thinking, okay, maybe let's get rid of the combination, let's get rid of the hydrochlorothiazide, let's continue on a cilazapril. But then you realize there's another notification which has come through from Pharmac. And cilazapril, we are in a single manufacturer situation, and there's no guarantee that we'll have supplies after 2022. So at least in the near future, you might be fine, but in a couple of years, you might have to change into something else. So you probably are going to factor this in when you're taking that decision. So feedback also had highlighted this point that 60% of the people taking ACE inhibitors in New Zealand have been prescribed cilazapril. I don't know why, but it's probably one of our favorite drugs. So most of us kind of end up using cilazapril. So what are our options? So cilazapril, let's say if you don't want to use cilazapril and you want to go on to something else. So the other funded ACE inhibitors are enalapril, lisinopril, perindopril, and quinapril. Now out of this rest 4, you have the option to use a combination pill with quinapril. If you are still keen to use that combination pill which he was on, you can substitute for this one. I'll tell you out of these 4, my favorites, I mean, they're all very, very similar in terms of efficacy and in terms of side effects. but my favorite is generally perindopril as well as lisinopril. So I use perindopril a lot more than many people, just because I feel these two are truly once-a-day pills, and therefore I lean more on them. But feel free to use any of these. For enalapril, you might have dose twice a day, and so is quinapril. So in terms of your options now, you're going through the list. If you want to use the class of ACE and diuretic, so as a combination, you've got quinapril or hydrochlorothiazide. Now there's another combination pill, just FYI, which is with losartan. That's a good alternative too. So you can use this, or you can use this combination pill. If you're okay with not using a combination pill, then there is a good option that you can use perindopril and chlorthalidone. Remember, chlorthalidone is almost twice as potent as hydrochlorothiazide, and it's longer acting. So this could be one of the options. So can this work? Yes. Next, if you want to use a combination at a lower dose, but add another pill, which could be a calcium channel blocker, so you can use this combination pill and amlodipine. So you still are on 2 pills. Would this work? Yes, this should work. Other option, you substitute to ACE inhibitor and calcium channel blocker, which I told you based on accomplished trial is a very good combination. So I many times use perindopril plus amlodipine. Both are longer acting pills. So would it work? Yes, it would. Then you're thinking about, okay, what if the patient has or develops pedal edema? So maybe you don't want to trial a calcium channel blocker. You're thinking about a beta blocker. Would this work? Yes, definitely this will work. This will bring down the blood pressure. But at the same time, why would you use this option? Because remember, beta blockers are mainly indicated in specific patients. So unless there's specific indications, you generally won't use them as your first or second line of antihypertensives. So indications would be post-MI or congestive heart failure. These would be 2 important indications. If that's present, then yes, go for this one. Sometimes people use this combination with the alpha-1 blocker. Now again, the question mark is because why would you use that? Because you've got other better combinations here. But you can use doxazosin, especially in a 73-year-old, if he has prostatomegaly or prostatism, and if he's got symptoms of that, that's going to help. To be honest, I prefer tamsulosin more than doxazosin, because in the ALL-HAD trial, there was increased risk of heart failure with this pill, but you need special authority and intolerance to doxazosin to be able to prescribe that. The last combination, which I've just thrown it out here, is ACE inhibitor plus angiotensin receptor blocker. And I'll just say by the smiley. I love smileys because they speak louder than words, I believe. So unless you're pushed really hard, you probably are not thinking of this combination based on the on-target study where it showed increased risk of hyperkalemia and acute kidney injury. Now, I've just been talking about the ACE inhibitors, but there's this ARB group. We've got 2 funded ARBs, which are really useful. And losartan, as I said earlier, has this combination with hydrochlorothiazide. So mostly you can interchange ACE with ARB, and you get away with those cough side effects of ACE inhibitor. So many times I would just start candesartan. Now for the past 2 years or so, we don't have to have intolerance or cough with ACE inhibitor to be able to prescribe ARB. So I generally use candesartan. Losartan, I try and use in patients with history of acute gout, so recurrent gout, because losartan is the only antihypertensive which can give you a little bit of uricosuric effect, and that might help a little bit with gout. So I keep that in mind. And so BPAC gives you this this slide where you can decide whether you want to use ACE or ARB. So main indications would be heart failure, myocardial infarction, and hypertension for ACE inhibitors, and kidney-related issues for ARB. But most often we use them quite interchangeably. So as far as our case goes, after the first follow-up, you're still kind of happy with your target you're trying to achieve, and then you decide, okay, cilazapril and hydrochlorothiazide is anyways going to go off the market very soon. You decide to use an ACE inhibitor and amlodipine on a good dose to be able to achieve this target, and then you plan to follow this patient again in next 2 to 3 weeks as to how far he's been. The patient asks you, what should I do? You give me 2 pills. Should I take 1 pill in the morning, 1 at night? And that's a relevant question because there's been this talk about nighttime dosing that's been going on for a while. One of the earliest studies actually showed that it improves cardiovascular endpoints. And it makes more sense to take some pill at night just because you have this very early morning surge in the sympathetic activity and the blood pressure goes up. If you control that blood pressure, your risk of cardiovascular events is lower. But there were some fallacies with that study. It was a subgroup analysis. I'm not going to go into the details, but don't take it on face value, especially that study. There were other studies which have looked into this, and there's complete contrasting data. There's another study which is in progress called the time study that will tell us what time is more appropriate for our patients. But hey, like it's a simple thing. Many times I do prescribe them to take it at night. It does no harm. If at all, it will do some benefit, which is still to be proven. So if the patient wants to split it and you're happy with that, then he can take one of the pills at night. So you see this patient after another couple of weeks, and the patient presents with a blood pressure which is really well controlled at the target you were looking for, but now he's developed some postural symptoms and he's not happy about that. So in your head, you're like, okay, maybe this is too well controlled blood pressure, so you want to reduce the antihypertensives. Now the question is, which one do you reduce? What would be your preference? Would you reduce the ACE inhibitor, perindopril, or would you decrease or back off on the calcium channel blocker? So you can do either or, but just something to keep in mind that the ACE inhibitors are first line if the patient has any of these: proteinuric CKD, our patient doesn't have heart failure, LV dysfunction. So if this is present, you definitely are going to try and keep that ACE inhibitor on and maybe back off on the amlodipine. But if not, then it's your choice basically. And with the increase in creatinine, you're probably thinking, let's back off on the ACE inhibitor. So your final plan for this patient is a goal blood pressure of 125 to 130 systolic, and that's a manual blood pressure. You asked him to continue with lifestyle modification. You ended up stopping the perindopril just because you were concerned that the creatinine might jump up even further. Mind you, 25% to 30% increase in the creatinine is still acceptable because that's how the pill works. It reduces the GFR temporarily, but you'd see no specific indication for him to continue on that. Hence, you continued on a calcium channel blocker, which is completely appropriate for a patient who's 73-year-old. So that's your final plan for this patient. Now I come to the next point, which was hypertension in the elderly. Now, as you continue following this patient as he gets older and frail, you want to keep some things in your mind. Especially in the elderly, there is this fine balance that we need to maintain about benefit versus harm. Now, previously we were, if you look at the HIVAT trial, they talk about less than, and the blood pressure less than 150 is still okay as compared to something higher than that. But more recently with SPRINT trial, it showed benefit even in the older patients who are frail. So even in those patients, it showed benefit. And it kind of makes sense because these are the patients with higher risk. So higher the risk, more is the benefit. So you definitely want to go lower on their blood pressure if they're able to tolerate that. So some of the benefits which have been proven are improvement in their mortality rates, reduction in the cardiovascular events, reduction in stroke, and more recently there's been literature published about improvement in dementia if you have stricter blood pressure control. So definitely that's quite a few good reasons for you to try and achieve better blood pressure control in these patients. But you're also concerned about the harm in these patients as they get older. There are a few issues. They tend to develop orthostatic hypotension more commonly than other populations. In some studies, they will tell you that about 20% of the patients will have this orthostatic hypotension, which essentially is drop of blood pressure of 20 systolic or 10 diastolic within 2 minutes of patient changing position from supine to standing. So you have to be careful, because if they feel dizzy, they can break, they can have easy fractures, they are frail, and then you've done more harm than good for these patients. And also there is this case of postprandial hypotension. So after they've had the meals, they tend to have a bit of hypotension. So that's common in the elderly. And in terms of frailty, different ways to define frailty, but there was this French and Italian study which showed that the outcomes were actually quite poor if you treat the really frail people and you keep their blood pressure quite low. So that's something we need to keep in mind when you're treating this. So some of the thoughts you had in elderly people is these people tend to have more comorbidities. So you'll see higher prevalence of chronic kidney disease or congestive heart failure, but these are the patients with high risk, so they might actually benefit more. They also tend to have cognitive impairment. So this is important because they may forget taking their pills if it's, if it's polypharmacy, it's a complex regimen, multiple dosing, 3 times a day pills. They tend to forget these. So we've got these phone apps and all these things, but if the patient is going to become non-adherent because we didn't simplify the regimen, then it's not a job well done. Frailty I just spoke about. If you're using diuretics and ACE inhibitors, they tend to have electrolyte abnormalities. I'm really concerned about giving high-dose diuretics to elderly because they tend to run the risk of hyponatremia, which is really concerning. I've seen quite a few people getting admitted to the hospital for that because it becomes symptomatic, and the risk is higher with thiazide, which is one of the common diuretic that we use for blood pressure control. There's also this concern about low diastolic blood pressure and what it actually means. So systolic blood pressure tends to correlate with outcomes more than diastolic. But then there's a general feeling that you should not reduce the diastolic below 60 because that can cause impairment in the cardiac filling, and the filling pressures are low. But in general, it tends lower diastolic blood pressure tends to reflect the comorbidity that the problem the patient has with the blood vessels and the cardiac status. Quickly jumping to another case, just to reinforce the same points we made, just to give you another example.
Right.
So
before we do, would it be okay if we had a few questions?
Sure, please.
The second case. Okay. So just sort of working with basic logistics. When you're talking about increasing doses, how often do you check the blood pressure and how often do you increase the dose?
So I generally recommend following the patients after 2 to 3 weeks of changing the medication, because the peak time to have a complete thorough effect of any pill would be somewhere between 1 to 2 weeks. If somebody's been put on spironolactone, which is again one of my other favorite pills, which I didn't talk about today because that's kind of the 4th line pill, then you might follow them up a little bit later, 3 to 4 weeks, because spironolactone kind of you see the effect even after 2 to 3 weeks, that they're still having some improvement in their blood pressure control. I practice at Middlemore, and it may not be easy for me to get the patient in earlier. So many times my changes would be a lot more dramatic based on experience as compared to what I would suggest should be done in especially in the primary care setting, where you might be able to, depending on the practice and depending on the patient, you might be able to see them more frequently, which is the ideal case. So you should be seeing them every 2 to 3 weeks until they are very close to their goal blood pressure. Having said that, there's no rush to control their blood pressure. If they don't have acute hypertension, if they're not really symptomatic, they don't have end organ damage, generally they say you can take months, which means anywhere between 3 to 6 months to bring them to their goal blood pressure. So what I would suggest, if you're starting somebody on any antihypertensive medication, maybe follow them for the first couple of visits a bit close to the change. And then once they are closer to the target, let's say they hit 150, then you might kind of space them a little bit further away.
Now, we brought off the session by talking about ACE inhibitors. Someone's just made a comment that under the NICE guidelines, they advise calcium channel blockers for people over the age of 55. So is there any difference in terms of choosing one over the other in this particular case?
So, yeah, NICE guidelines, they are slightly different. And my colleagues who are from UK, they love NICE guidelines. And I've got soft corner for the CHEP guidelines. To answer the question, the mechanism of hypertension in the elderly is supposed to be non-renin mediated. So physiologically, if you're looking at the pathophysiology of hypertension, they do not have renin-mediated hypertension as much as a younger individual would do. And therefore, giving them ACE inhibitors physiologically doesn't make too much sense. And they tend to tolerate a calcium channel blocker much better than the ACE inhibitor, especially if they have mildly impaired renal function or if they have got some other issues. then my first choice, obviously, I've actually put that in one of the slides towards the end, that my personal choice in this population is a calcium channel blocker. Though with that, some patients do develop pedal edema, which is really annoying. And then I might choose to use a smaller dose of calcium channel blocker with a small dose of an ACE inhibitor.
On one of your slides where you had a number of different potential options for blood pressure combinations, you did mention that there was a place for beta blockers after a myocardial infarction. If this is the case, someone's just wondering how long you would keep them on that particular medication before considering a change, or would you change after myocardial infarction later on?
No, so the two important categories of antihypertensives after a myocardial infarction would be your beta blocker and an ACE inhibitor, and I would leave them lifelong if they're able to tolerate that.
Great. And then just before we move on, there's just a couple of people questioning, do you treat isolated systolic high blood pressure in the elderly?
Yes, you do. There are quite a few trials, including HIVET trial, the hypertension in very elderly, which use indapamide actually versus placebo to show that if you have isolated systolic hypertension and you treat that, then the outcomes are much better. So I would certainly treat isolated systolic hypertension.
Thank you.
So just moving on to, this is very brief, just wanted to reinforce the same points which I've discussed earlier in a slightly different context. So let's say another 69-year-old gentleman who comes to your clinic. Now this guy is quite different. He's retired and essentially he's been in lockdown even before COVID began. What I'm trying to say is he's not a really active person. He doesn't exercise. He's got issues with alcohol. He drinks almost every night. To this day, stranded drinks. He's still smoking despite being told to stop on numerous occasions. He essentially is living on canned food and takeaways. The point here I'm trying to make is this is salt-rich generally diet, whereas you would want somebody like him to kind of not be taking too much salt. His past medical history is significant for diabetes, hypertension, dyslipidemia, and gout. Thankfully, he's not had any cardiovascular events so far. In terms of medications, he's not taking any of the medications prescribed by his previous GP. He doesn't believe in taking medications because he's asymptomatic, so he's like, I don't need to take any medications. He takes naproxen on and off when needed, and that's the only thing because when he's in pain, he needs something urgently. So you do an exam on him, his blood pressure is elevated, 160, 190, and you recheck it on 2 occasions to make sure this is genuinely elevated blood pressure, and this is seated blood pressure with all the right technique. These are the labs in front of you. His GFR is fine, but he's got a bit of proteinuria of roughly just over 1 gram per day, which him being diabetic and hypertensive, you're thinking in terms of diabetic nephropathy, he's already established diabetic nephropathy that he's got despite the GFR being reasonably okay. His cholesterol is 5.7 with an HDL of 0.9. Again, the same principles. How aggressive you're going to be in this patient. Mind you, he's been non-adherent, doesn't like taking pills, so you have to be careful. So you do a risk assessment, same thing. You look at the predict risk assessment, and his 5-year risk is 31.9% for a cardiovascular event at 5 years. So this is really high, and therefore you try and explain him that you'll definitely benefit from interventions, and then we need to do something urgently. So you asked him to stop smoking, and the other good thing with this tool is that along with the smileys, it gives you numbers and shows you the change with different interventions. So let's say if you ask him to stop smoking, his risk, which was 31.9, drops to 22.1% just by that intervention. And there are many other interventions which can add on to this. So you show him that if you start the medication and he starts taking those, the risk drops even further to 11.9%, sorry, 11.1%. Quite a bit of benefit if he starts taking his pills. So this is the way, in a way, you're trying to convince him to be adherent and start taking the pills, and you're trying to rationalize his medications. So therefore, you come up with a management plan for him after he's agreed to take the pills you're going to prescribe. So you start him on losartan on a low dose of 25 milligrams. You want to test the waters, and the plan is for up titration. The reason you choose losartan is he's already got an established diabetic nephropathy because the proteinuria of a gram, which I just showed you earlier, and he's been long-standing diabetic. So in your head, you're already aware of the goal. He's high risk, so you want to bring him to less than 130 over 80, or if possible, less than 1 or closer to 125 with the manual blood pressure monitor, so slightly lower than usual. And in the long run, in your head, you already know that this may not be enough for his blood pressure control, and you're going to increase it gradually. So you might want to think about using the combination pill with losartan, which is already there. He's a patient with gout, hence you chose losartan. It gives you that tiny bit of extra benefit compared to candesartan. And the other advantage is you can change from losartan to losartan hydrochlorothiazide as a combination pill. If despite this the blood pressure doesn't come under control, then the next best option is amlodipine, and then you're going to consider metoprolol or bisoprolol if there is history of coronary artery disease, and looks like he's at a high risk, so you may end up developing one of those. Doxazosin only if he's got prostatism. Remember, doxazosin had increased risk of heart failure in the big all-HAT trial, so keep this as probably a 4th line or 5th line drug. And then you're definitely kind of reducing the cardiovascular risk. So you're assessing whether he needs to be on statin, which probably needs to be, and also you're looking at whether you want to start him on aspirin. But at the same time, you're going to reinforce lifestyle modification because I don't think so I put in that slide, but last time and the last webinar I'd shown you a slide. If you add on all the lifestyle modification, you're probably looking at reducing the pill burden by 1 or 2 blood pressure pills just by these interventions. So this is your management plan for this patient. So in summary, because we are almost running out of time, I'll just summarize with a few important points. We need to individualize the blood pressure targets based on individuals' cardiovascular risk, which we use the predict risk calculator. Gone are those days where we used to say one size fits all. Now we individualize treatment. So this is a good tool, as I've shown you. And remember, if the cardiovascular risk of anyone is high, these are the patients who would probably benefit the greater from reduction in blood pressure. And for most patients, I'll show you another slide after this, just as a summary slide. For most patients, the target offset blood pressure is going to be 125 to 130, especially in the elderly patients where the risk is slightly higher. And just remember, if you are treating elderly patients with a stricter blood pressure target, as the management intensifies, the number of adverse effects going to go up because you're going to use more pills or you're going to use higher doses. And then as they grow old, you have to keep in mind frailty and postural hypertension. We have to do good, so we have to be careful about the potential harms we can induce. Some of the points which we need to remember here that importantly, the automated blood pressure, which we use fairly commonly, and in fact, I encourage quite my patients to monitor blood pressure at home using the automated blood pressure monitor. And the readings tend to be 5 millimeters lower than the manual what I check in the clinic, so that's to be kept in mind. This pill is going to go off the market. Cilazapril in the next couple of years may also disappear because there are hardly any countries which use this. Lisinopril, perindopril are good options. ARBs are also good alternatives, so losartan and candesartan. And if you're keen to use a combination pill, these are the 2 available options that are funded. And Grace, as we mentioned earlier, the calcium channel blocker are generally my first preference in the elderly, unless they develop any adverse effects to that. ACE and diuretic are pretty good alternatives for these patients. So just a summary slide about the blood pressure target in different conditions. So elderly, CKD, cardiovascular history. All these are going to be high-risk populations. So if you do a predict risk assessment, it's going to be high, and therefore the blood pressure targets are fairly similar at less than 125. Now these are office blood pressures, mind you, so manual, not automated. And the baseline risk matters, so bigger the risk, bigger is the benefit. And that's pretty much it for tonight from me. I'm happy to take any more questions.
Great, because we do have some. Thanks, Hari. Just going back to case number 2, there's just some commentary that had came through, just talking about the thiazides. Really, that sort of thought around how the thiazides make gout worse. So what would be your rationale for choosing that particular medication, the combination one with the hydrochlorothiazide?
So you mean choosing the combination pill with hydrochlorothiazide, especially in a patient with gout?
Yes.
Yeah. So the only reason you're going to think about that, again, I'm not saying we must use this. This was just an example. The only reason why you're going to use this pill in this patient is, I had mentioned upfront that this patient is completely non-adherent. And so if you look at the data about adherence at the end of first year, probably 1/3 of your patients are going to stop taking your pills regularly, which you prescribe. At the end of 5 years, roughly 40% will be taking those pills, so 60% will stop taking those pills. Things have improved slightly, but non-adherence is fairly common. So for somebody who is already a known non-adherent, the only rationale to use a combination of hydrochlorothiazide in such patient is to reduce the pill burden, and thereby you're giving them less pills, and then the patient might take those pills. And we see this very commonly, especially at my hypertension clinic that I run. Non-adherence is a big problem. Now, that's a fair comment. If the gout is not well controlled, I would refrain from using a thiazide or any other diuretic for that matter.
Okay, now we've just along that theme of thiazide, someone's just posed a question: does hydrochlorothiazide increase the risk of skin cancers?
Oh, I'm really happy somebody asked that. We've got this. I've started part of the hypertension group in Auckland, and we've got a few colleagues from Northland and Waikato. So I had raised this issue about the diuretics causing skin cancer. There are these studies from, I think it was a Scandinavian country, if I'm not mistaken, but definitely from Europe, which showed that slight increase in the risk of use of ACE inhibitors and also the thiazides with skin cancer. The risk is very, very small, but it's definitely there. So the consensus, and it was in fact my thinking that I deal a lot with the transplant patients. So kidney transplant patients, I'm the lead at counties for that. Our patients tend to have an increased risk of skin cancers for 2 reasons. One is the geography. Australia and New Zealand tend to have higher skin cancers because of the ozone depletion and exposure to sun. And also they are on the pills which increase the risk of cancer. So in these patients, whether we should be careful, whether we should avoid them, again, if there are any other alternatives, you can keep this in mind and use the other alternatives. But the risk is known to be very, very small, and there's no conclusive evidence that there's no cause and effect kind of study, but there's an association. So you can bear that in mind, but having said that, the risk is fairly small.
Okay. Now, just thinking along that space of the blood pressure machines, how much can an automated machine at home differ in blood pressure readings from the manual ones that we do in the office?
So the automated ones and essentially the ones in sprint trial, they tend to give a reading of at least 5 millimeters lower than the manual one what we have in the office. So make that correction for the office blood pressure, which is 5 millimeters higher. If you're looking at a blood pressure reading of 160, the difference could be as big as 10 millimeters. So 160 office blood pressure manual may correspond to 150 with the automated. 2 things which I would highlight. One is when we bought the automated blood pressure monitor for the clinic, we got them assessed by our engineering department, and the brand new machines showed a difference of 10 millimeters themselves. So that, I mean, they're not the most accurate. So there's already that difference. Number 2, most people use automated blood pressure machines at home. Home blood pressures tend to be lower in any case on most occasions. So you have to factor that in as well. But to answer your first question, the question clearly is the difference is at least 5 millimeters of mercury compared to the manual one.
Okay, fabulous. Now, would you be able to just tell us about how much an effect does salt restriction have on lowering the blood pressure? And how do you teach that to a patient? How do you convey that information to a patient?
Right. So salt restriction will have up to 5 millimeters of mercury, which is almost practically saying half a pill difference in terms of reducing the blood pressure. The way it works is actually salt sodium interferes in the mechanism, the action of the blood pressure pills. So that's one way. Second way, it tends to kind of hold the water with itself and increases the blood volume. So intravascular compartment increases, causing blood pressure to go up. So these are the mechanisms. And so you get a benefit of about 5 millimeters if you really strictly control the salt intake. The way I explain to them is twofold. One is I've got a list of sodium containing foods and I show them the page. They take it home, basically. The other resource that I have is some of the dietitians in our department have a bit of interest in hypertension, so they do this group education session intermittently, and they also highlight the same thing. The way I assess salt intake or sodium intake, because there are cases where I'm increasing the antihypertensives and the blood pressure is still not well controlled, I subtly would ask them to do a 24-hour urine sodium and creatinine collection. And somehow many patients agree to do that they don't really know why I'm exactly asking, but I wanted to kind of see the sodium intake. So if the 24-hour urine sodium is high, especially more than 200, I would tell them that you're still taking a lot more sodium than you're actually agreeing to or admitting to. So these are some of the ways kind of I deal with salt intake, but this is really important to address. Otherwise, you keep increasing the medications, the blood pressure doesn't respond that well, and you wonder if the patient is not taking or is there something else going on there.
Okay. Now, talking about people with non-responsive blood pressures to medication, what would you suggest if you had a person whose blood pressure was still quite high despite maximal antihypertensive doses on perindopril, amlodipine, and metoprolol?
So I would make sure that the patient gets a diuretic if there are no contraindications, obviously. My fourth pill, in fact, probably would be earlier than the other pills unless contraindicated. Diuretic is important. A diuretic also is a part of the definition of resistant hypertension. The reason being sodium, again, plays an important part in resistant hypertension. So the diuretic would get rid of the extra sodium or salt and thereby make the blood pressure more sensitive to the other pills. So that would be my approach. If despite using a diuretic and the patient is on maximal doses of 3 pills, then the patient fits into resistant hypertension, then I start looking at what are the causes of resistant hypertension. Is there anything else going on? So let's say this morning I saw a patient who's got a history of peripheral vascular disease and has been smoking, and I tried to feel her peripheral pulses. I couldn't. So in my head, I was thinking of whether this patient has renal artery stenosis because she's got evidence of peripheral vascular disease, which many times would fit in with the diagnosis. She's been a smoker, so there is this issue with the blood vessels, if I have to say that way. So yeah, then you have to start thinking, what is it? Secondary causes. So renal artery stenosis, primary aldosteronism, pheochromocytoma are very rare. In South Auckland population, obesity and sleep apnea are really underdiagnosed. I used to joke about driving in Auckland when I came here from Canada, but sometimes I wonder whether many of these are actually undiagnosed as sleep apnea. And that's one of the important causes of hypertension. So we need to address these things. My fourth line, if I've tried all this, is the medication that I like is spironolactone. That's really underused, and we could use that more often, I believe.
Thank you. Now, just as a reminder, would you be able to just mention again our alpha blocker choices, which ones to avoid and why?
So alpha blockers, we're talking about doxazosin or terazosin. They are antihypertensives. They do work. Some people though question whether they work by themselves as a single agent, but they do work. The reason why I keep them as fourth line or the fifth line antihypertensive medication is because of the big trial called ALLHAT, ALLHAT. If you want to Google that, it's a landmark trial. So the trial basically was of 4 arms trialing out different medications. So they were comparing ACE inhibitor, calcium channel blocker, a diuretic, and the alpha-1 blocker, doxazosin. And they had to stop the doxazosin arm before the study could even be completed because they saw increase in the risk of new heart failure in that population. And if you talk to the cardiologists as well, they don't fancy this pill as much, and just because of this issue. So if you have the choices, you might as well keep this lower on the list and use the other choices that you have. Doxazosin more commonly is used in the elderly males here because it's an alpha-1 blocker and helps with the symptoms of prostatomegaly, prostatism as we call it. And it's useful in those cases. And that could be one of the indications that you might be pushed to use it. And I prefer tamsulosin, but it's by special authority. So I end up many times using doxazosin myself, but I'm not a big fan of it.
Okay, now moving on to the calcium channel blockers, do you have a particular preference for one or the other, or any particular calcium channel blocker?
So I got used to using amlodipine quite often because we did not have felodipine in the center where I was in Canada. Having said that, both work well. Amlodipine is truly, again, as you know, longer acting. Felodipine is made longer acting by using the extended release preparation. There is a comparative study which looked at the efficacy of both, and there's this weak evidence that amlodipine works better, even in patients who do not really respond to felodipine. So there is a slight extra benefit with amlodipine, and my choice is amlodipine just because I've been using it ever since I was in med school, in fact, after med school. So that's my preference, knowing well that it's very similar to felodipine, but maybe slightly better in terms of people responding to it.
Okay. Now, is there any role for diltiazem or verapamil when we're thinking about calcium channel blockers?
Yeah, so I completely skipped one section focusing on the non-dihydropyridine and dihydropyridine. So calcium channel blockers, diltiazem is one of the old school drug. It works well. There are studies to tell you it's kind of one of the potent antihypertensive medications. The only reason that I don't use it as often is many times I have patients which require beta blocker for indications such as heart failure or MI, and diltiazem and beta blockers, they're both heart rate limiting, so I can't really maximize the doses, and the patient runs a risk of having bradycardia, and therefore I prefer using a combination of let's say calcium channel blocker such as amlodipine along with a beta blocker. Because the calcium channel blocker is then going to increase the heart rate, theoretically speaking, at least not reduce it. So that's the only potential advantage. Otherwise, you can use diltiazem is being used more often. Verapamil, not so commonly used, to be honest.
And would you be able to tell us which calcium channel blocker has the lower risk of pedal edema as a side effect?
I think they're dose dependent. So depending on what dose you use, if you use any of these, the incidence of pedal edema is fairly similar with both amlodipine and felodipine, slightly lesser with diltiazem probably, but it depends on the dose. So sometimes it's difficult to compare between these medications. Many times it's a class effect. So if you use felodipine and patient develops patient develops pedal edema with that calcium channel blocker, if you substitute with another one, you might still face the same issue. The reason they develop pedal edema is the way it works. It reduces it relaxes the venous musculature. So there is relaxation of the blood vessels in the legs, and that leads to pooling of the fluid and leading to pedal edema. So people who are sensitive will develop with almost all the calcium channel blockers.
Okay, now with chronic renal disease, how do you manage patients with that particular problem who are also using thiazides?
You mean the pedal edema?
Sorry, I've moved on to the thiazides and impact on renal impairment, or renal function, I should say. If someone does have chronic renal disease and they're on thiazides, how do we manage it? So do we need to lower the dose? Do we need to actually take them off it?
Right, so thiazides would work well. They are potent antihypertensive medications compared to the loop diuretics, which is furosemide. They are not as potent in terms of reducing the pedal edema, though they still do, but not as potent as furosemide. So if you're looking at if the patient has really low GFR and you're trying to address the pedal edema, then you're better off using furosemide than hydrochlorothiazide or chlorthalidone for that matter. But if you're looking at blood pressure control, then you're probably looking at the thiazide diuretics. And said that thiazides don't really work that well if the GFR is less than 30. The only exception being chlorthalidone, which you can probably use until the GFR of 10. Having said that, between 30 and 10, the efficacy definitely reduces. So if the GFR is less than 30 and the patient has either edema and you're trying to address that, then it's better you change onto a loop diuretic such as furosemide. Now, furosemide, just remember to dose it twice a day, preferably. It's not a longer acting pill like torsemide. Torsemide is not available here. I've got good experience with torsemide, very potent, but we don't have that option. So the ideal thing would be to break furosemide into two different timings. So BD dose, if you're using 40 milligrams, just break it into 20 in the morning, 20 in the afternoon. There is a rationale behind that is if you're giving just once a day pill, the effect wears off in 4 to 6 hours, and after that the kidney will try and compensate by absorbing more fluid and sodium, in fact sodium and therefore fluid. So you're kind of negating the benefit you received from the morning pill. So try and dose it twice a day if possible.
Okay, now I'm sure those of us who have been doing general practice for a while have probably come across this problem. So I was just asking, if you have a patient that presents to you as a new patient and they've got a very high blood pressure, and they've given the example 210 over 110, how do you treat these patients, particularly if they're in the older age bracket?
So again, it depends on the context of the patient. Somebody who's completely asymptomatic, does not have any evidence of end organ damage, you can treat them. You probably will have to start 2 pills at one go or use a combination pill, and then you have to bring them back sooner than later. So maybe follow up in a week or a couple of weeks. The advantage that I have at the hospital is we got a subacute clinic, which is managed by the registrar, and I've upskilled a couple of nurses to do the up titration clinic. So I've got this extra slot somewhere with them where they see the patient and discuss with me. So what I'm trying to get to is, like, if there's no end organ damage, you started the pill, you're confident the patient is going to take the pill, there is no extreme urgency for the patient to be hospitalized. I was discussing with Bruce Arol the other day about this same thing, that many people in US get hospitalized, and that's actually shown to be kind of counterproductive in such cases. But I was just discussing with him that US is a completely different system. If something happens, 1 in 100 chance that something is going to go wrong with such patients, you'll be getting into $1 million litigation. So they kind of quite practice many times defensive medicine. But there's no, if you read the guidelines and all, there's no rush for these patients to go to the hospital, and you can control the blood pressure over a few weeks. If the patient has evidence of end organ damage, kidneys, heart, you do a fundoscopy if people are able to. and there is papilledema, then these patients, you are better off sending them to the hospital, because then you want to control their blood pressure much quicker than you otherwise. So it depends on the context of the patient.
Okay, and then just one last question. Do you have any tips for us, for those of us out there trying to manage white coat hypertension?
So the easiest trip, which may not be easy, it's easier said than done, is to get the patient to check the blood pressure at home. And so if they check the blood pressure at home and the blood pressure at home is fine and the blood pressure in the clinic is elevated, you pick the diagnosis. This is white coat effect. It's called white coat effect if somebody is already on hypertensive medications. It's called white coat hypertension if somebody is not on any pills. And so let's say somebody just comes to you, blood pressure sign, never been on pills, goes home, checks the blood pressure again, it's fine. So that's called white coat hypertension. So that's the easiest way. The other short way to diagnose is by getting a 24-hour blood pressure monitor. I think it's easy to access in private, but not as much in public. So yeah, that's probably the best way. I have actually done that. I've loaned my own automated machines to the patients. I bought 3 machines for myself. I've got one left, 2 disappeared. But that was the whole idea. They could not afford to get a 24-hour blood pressure monitor, and I wanted to check if they got this white coat effect on them.
Thank you very much. Well, Hari, we've come to the end of our session today. It's been great. I've picked up some really handy tips with regards to my own hypertension management of my patients, and I'm sure those of us out there who were listening in today also did as well. So thank you.
I'm glad. Thank you for having me.
Welcome. So once again, everyone who's out there listening tonight, thank you so much for joining us. Really appreciate those questions coming in. It makes it really dynamic, and I hope you all have a lovely evening.